Okay, hello everybody. Thanks for joining us this evening or this morning, wherever you may be in this world. I'm super honored to host my dear friend, a star deformity, or actually all around spine surgeon, minimally invasive deformity surgeon, who's always on the cutting edge of technology. Dr. Andrew Grossback, he's the also an educator, a part of being a supreme surgeon. He's an educator. He is the residency training program director, as well as the spine fellowship director at the Ohio State University Department of Neurological Surgery. So tonight, or this evening, or this morning, he'll be speaking with us about the role of artificial intelligence in preoperative planning in adult spinal deformity surgery. So, Andrew, thanks for joining us, and the floor is yours.
Awesome. Thanks, Nader. So we're just chatting a little bit before. If everyone gets a chance, check out the Ohio State-Iowa football game tomorrow. Nader and I both trained together at University of Iowa. I'm at Ohio State now, so I have a little bit of a torn allegiance, but yeah, should be hopefully a good game. I'm actually covering the game, so I'll be on the sidelines. Got some, right behind the team. So hopefully you don't need me and I can enjoy the game. But yeah, should be fun.
Yeah, we'll look for you on the sidelines.
Yeah. So yeah, today I'm going to be talking about a little bit on AI and preoperative planning for adult spinal deformity surgery. For some disclosures, I think the only relevant one is some consulting fees from Medtronic. I will be talking about their UNID platform for deformity correction planning. I didn't have anything to do with the development of this software, but I have given a couple sponsored talks on it in the past. The more important disclosure is I am not smart enough to understand machine learning or artificial intelligence. So today I'll be talking about kind of the current state of machine learning in spine surgery, what currently exists, like what can we use clinically, and what are some future directions and what we're doing at Ohio State. Surgical planning obviously is very important to good outcomes in adult spinal deformity surgery. Improper planning and or improper execution can lead to suboptimal outcomes. Broad fractures, pseudoarthrosis, either over or under correcting, which can lead to proximal junctional kyphosis, proximal junctional failure. And also of vital importance is, patient selection. These are very morbid surgeries, high complication rates, and patient selection is very important. So how do I do my planning? Up until about a year ago, this is how I did it. I would sit in clinic. I like to do a lot of my planning at the time when I see the patient, I'm looking at the x-rays, I come up with a plan. So I show up on the day of surgery, I know what I'm doing. I don't like to show up and then try to make last minute decisions and stuff. I like to have a plan in place. So I would draw out these measurements and more measurements on our PAC system. It was a manual process. I'd draw them out, I'd write down the measurements and try and come up with what I was going to do. A lot of times this is imprecise. You're kind of visualizing where's that end plate, trying to draw it out. I'm typically running way behind in clinic. And so I didn't feel like I always had, adequate time to do this. So sometimes I try to come up with a little bit of a plan. Next time I'm in my office, do the rest of the measurements. But I was really looking for a better, more streamlined way of doing this. For a number of years, there's been some preoperative planning software, and I've played around with a couple different programs and just didn't feel like I was, made a whole lot of difference. So it's kind of the same measurements I was doing. The goal of this is, of course, to standardize the measurements. A lot of these are still based on surgeon expectations. So if I'm planning an L4 pedicle subtraction osteotomy and I say I'm going to get 35 degrees there, and then it says, okay, 35 degrees here. We're also kind of limited by our post-operative analysis. So a lot of the papers that are out there looking at, adult spinal deformity correction, look at your preoperative parameters and what do you get post-op? And they're better, sagittal balance is better, PIL mismatch is better, but did you actually achieve what you're trying to achieve? So a little bit on big data, machine learning, artificial intelligence. Those are all buzzwords across medicine, across multiple spaces, and across spine surgery. Really, what it is trying to leverage data to improve performance, and in our case, to improve clinical outcomes and decision making. We know spine surgery is one of the most heterogeneous surgeries out there. If someone has hip pathology and they need a hip replacement, if they go anywhere around the country or around the world, they're probably going to get a similar hip replacement, minor differences. Spine surgery is not like that. It depends on where you go. It depends on who you see. You might get a minimally invasive decompression. You might get a short segment fusion. You might get a T3 to pelvis with the pedicle subtraction osteotomy, or anything in between. So really the goal of all this is to, standardize, spine surgery. There's some early work being done right now on large data sets. One that comes to mind is the SLIP2 trial, looking at, low-grade spondylolisthesis and stenosis. And they're using a radiology-based machine learning algorithm to classify patients on, this patient's unstable, they need fusion, or this patient's, can get by with a decompression. There's been several papers. I'll reference a few of them here. One was a recent systematic review on machine learning in spine surgery. And basically their conclusions is they noted there's disparities in algorithm choice, database characteristics, and training methods across a lot of these. I'm not gonna show them all, but a lot of these, if you look at them, they're looking at, trying to predict adverse outcomes, adverse events, 30-day mortality, et cetera. Some of them are very large databases. The second one down on this list looked at, 1.1 million patients. But if you look at the data they used, these are public databases, and we know that, you can only get something, you can't get something better out than the data you put in. So you need to have the right data, you need to be collecting at the right data, you need to be looking at the right variables. Another area, we had a visiting professor recently from UCLA that their group is looking at, imaging and trying to predict, use machine learning to predict, who needs spinal decompression surgery. Right now, their algorithm in their one of their latest papers last year was able to over 90% predict, does this patient need surgery? A lot of this is based though on, expert opinion. And so, do they actually need surgery? If the surgeon thinks they do, that counts as, yeah, they need surgery. We're not always right. I'm not always right when I'm deciding this. So looking at adult spinal deformity, when, and a lot of this stuff is kind of looking at low-grade spondies or just stenosis, extrapolating that out to adult deformity surgery, which is, very heterogeneous, gets to be very problematic. So there's less in this space currently. I think one good paper out of the ISSG in European Spine Study Group in 2019, they looked at unsupervised AI-based clustering to identify a novel classification method. And their algorithm was kind of able to break these populations up into something that I think we kind of do anyway, which is like a young patient with, mainly coronal deformity, older patients with prior surgeries. So I'll probably see a lot of them. They get fused flat, they get adjacent level disease, and then older patients with, without prior spinal surgery. And then they looked at, surgical clusters. So no osteotomies or interbody fusions. So those are a lot of times going to be younger patients with, coronal deformity, flexible spines. They looked at use of interbody fusions. They looked at posterior column osteotomies, and they looked at 3-column osteotomies. They kind of broke these up, looking at what they could expect for improvement in patient-reported outcomes, ODI, SF-36, pain scores. They also looked at complication rates. So looking at each of these patient groups and then what surgery they got. I think, studies like this can show that this can be, somewhat helpful when you're talking to a patient like, hey, I think you need a pedicle subtraction osteotomy and you've had prior surgery and prior fusion, what are your major complication rates going to be? But other than that, it doesn't really help you decide, levels and how many osteotomies, stuff like that. So shortcomings so far, I think we're very early in this process. A big problem with this is as you add data points, you add complexity. And really to really get to the core of this, we're going to need to utilize multimodality imaging studies, not only scoliosis x-rays, but MRIs for stenosis, CTs for, fused and unfused levels for osteophytes, how flexible this is going to be. We need to incorporate patient-reported outcome measures, other outcome data, patient demographics, lab work, bone density, comorbidities. All of a sudden, you're getting these very, very large data sets, and to get all those entered into one place, even just getting that data is problematic sometimes. Largely so far, these studies are focusing on predicting poor outcomes, so complication rates, 30-day readmission, mortality, stuff like that. And ideally, we would remove expert opinion because if I'm super good at A-lifts and I say, oh, this patient needs an A-lift, this patient doesn't need an A-lift. Right now, a lot of the algorithms are good at saying, okay, we're going to teach it to detect when Dr. Grossbach thinks the patient needs an A-lift, and they're very good at doing that. Whether or not that's the right answer or not is a little less clear. So what currently exists for clinical use? How can we use any of this data right now in our practices? If you do a Google Scholar search for machine learning spine surgery, you get over 67,000 results. And so trying to make sense of what's out there in these publications, it's not easy. We're currently trying to figure out, just stenosis or not. So trying to use this stuff to predict, what we're going to do with this complex reconstruction is clearly down the road a ways. So are any of these things useful now? Not really, maybe. And I'll talk about kind of, what exists right now. So for the past year or so, I've been using the Medtronic Unit preoperative planning software. So this was a Medicrea product that was acquired by Medtronic. And I think it does have some advantages to the way I used to do things with, doing the measurements in the PAC system. First and foremost, it saves time in clinic. I tend to get a kind of an idea, hey, you have positive sagittal balance, you have flat back, you have back pain, you've failed your conservative modalities. I think you need surgery. But then I don't do all my planning, all my osteotomy cuts and everything like that in clinic. I rely on the software to kind of help me make those plans. I think another strength is the post-operative analysis. So I'll show some examples where I say you need a L4 PSO. I'm going to get this much correction, and then it kind of keeps me honest because then I see how much correction I got. So they might be better than they were pre-op, but did I achieve my preoperative goals? And if not, why not? And then we'll talk briefly, it does include patient-specific implants. And at first I thought, how useful is this going to be? I do a lot of rod bending and in situ bending. Do I need something to give me a patient-specific rod? Not always, but I'll talk about when I find that useful. So here's kind of the flow of this. Step one is uploading the images and the image analysis. It does case simulation, so simulates my osteotomy cuts. We get a patient-specific implant shipped for the time of surgery. There's case support, so whatever my osteotomy cuts are, I have a little sheet of paper that's taped on the wall. It says, here's where we're going to do our osteotomies, here's where we're going to do our interbodies, here's how much correction we think we're going to get at each of those. The data collection piece, so I have my preoperative images, my plan, all my postoperative follow-ups, and what their spinal pelvic parameters are. There is an aspect of machine learning. And so when you start, it's kind of based on, I think there's over 7,000 cases that they're basing, what they think an osteotomy is going to correct at each level, what they think a TLIF or an ALIF is going to correct, and then what sort of reciprocal changes you're going to see in the in the remaining flexible portion of the spine. So if you correct spinal deformity and they were compensating by flattening their thoracic kyphosis, how much is that going to relax, and where are they going to end up? And so we try to do predictive modeling with that. So here's an example of a fairly straightforward degenerative case, and they haven't had prior surgery. And so when I upload these images, I actually just tell my nurses, hey, we're going to use unit planning for this. And then they automatically pull all the preoperative images from our PAC system. And I say, hey, I want to know, I want to see one with an ALIF at 4, 5, and 5-1. I want to see one with L4 PSO. I want to see one with multiple posterior column osteotomies. And then they give you, plan A, plan B, plan C. And so you can see your preoperative spinal pelvic parameters and what you're able to achieve, or what you think you're going to be able to achieve based on those different plans. And then I can select my plan. I can say, you know what, plan A looks good, or plan B looks good. That's the parameters I'm kind of shooting for. Select that plan and then get my patient specific implant. The machine learning portion of it, so the more cases I do, it learns that, hey, Dr. Grossbach thinks he's going to get 35 degrees of correction with this PSO, but he only gets 25 degrees. So the next time I'm going and planning one, it's going to say, we're going to get 25 degrees there. Do we need to do some other osteotomies? Do we need to do other interbodies to try and get our alignment goals?
So Andy, quick question.
Sure.
So this specific example, like you're looking at this pre-op, these preoperative parameters, and then the options, plan A, plan B, plan C, and looking at it, just eyeballing it roughly, it looks like it's all more or less the same. So in terms of different plans, in terms of correction or maintenance of lordosis. So then which one would you select? Would it be, if the outcome would be the same radiologically? How do you base your
it's a good
based
question.
on like morbidity or like tell me about that.
Yeah. So this I went back through this is just an upcoming case I have. I lovingly refer to these as degen pelvis, because it's a degenerative condition where every level is stenotic. Obviously don't have the MRIs and stuff here, but this isn't like a sagittal balance problem. When you select your plan, then you go back, the plans you don't select go away. So I didn't have a good example of like large differences in plans. So there certainly are some, and I'll show some cases here in a little bit, where plans were very different based on what osteotomies we're going to cut and stuff like that. In this one, they basically planned what would things look like with, and I know it's really small on this, on the plan A, no interbodies, plan B, TLIFs at L4, 5, and L5S1. So didn't make a huge amount of difference with, we're not trying to get a lot of sagittal correction here. Typically in my long constructs, I like interbodies at my bottom 2 levels. And so for this one, I selected plan B because I want interbodies for anterior column support for fusions and stuff like that. But obviously here it's not a big difference in correction, obviously. In some of the cases I'll show here in a little bit, there's a little more difference, and I just didn't have the plans that I rejected. I just had the plans we went with. So I wanted to at least show that there was, the option to have, different plans, see different things and stuff like that. So we'll run through a few cases here, and feel free to chime in if you, have thoughts or anything like that. So first case, similar to the last one, it's pretty straightforward. And this is a very common, case that spine surgeons see. So 64-year-old has a history of L4-S1 fusion outside the hospital several years ago, presents with worsening back pain, lower extremity radiculopathy. No significant past medical history or surgical history other than her prior fusion. And she's intact. She has a little bit of an intelligent gait and some lower extremity numbness. Here's your patient-reported outcomes before. We typically give VAS, back and leg, ODI, promised pain interference, and physical functioning. That's what she looks like when she stands up. So she's a little off sagittally. She's not terrible. She's got a little coronal curve. This isn't terrible. So this in and of itself wouldn't drive me to say, oh, you need surgery. But she's relatively stenotic. She's got some low-grade spondylolisthesis, and doesn't really have a good stopping point up to the thoracolumbar junction. So this would be a case that I talked about, like this is a degenerative detent pelvis. Because I don't like to stop at the thoracolumbar junction. The goal here is to get her decompressed and to get her alignment better, and not fuse her flat. So we upload this to our unit planning software, and we look at different plans, and this is the one I selected. Decompressions and basically posterior column osteotomies at the 3 levels that are stenotic above her prior fusion. And then you can see above our construct, it predicts that she's going to have a little increased kyphosis above, because she's probably flattening that thoracic spine to compensate for a little bit of sagittal imbalance. And then this is kind of what she looked like after. So then we can compare this and say, what did she look like before? What's our plan? And were we able to achieve that plan? And on the right there, it shows kind of what her balance was before, what our plan was, how kind of close we got with our execution. And the blue line on the right, that's our patient-specific rod. So this is the shape of the rod that gets shipped. And in a case like this, it's probably not super helpful. Most of our correction is going to come from our osteotomy cuts and just laying on a Jackson table. But I'll talk about a case in a little bit where I do think these patient-specific rods can help a lot. And then we see her spinal pelvic parameters, our pre-op, what we plan to get, and then what do we get? So we plan to get 43 degrees of lumbar lordosis, take her PIL mismatch from 23 to 8, and did we get there? Yeah, we did. We got actually a little more correction. So her 1 week, immediate post-op in the hospital before she goes home, and then at 1 month and 2 month, we're able to maintain that correction. Then looking at her, SVA, she went from 8.8. We plan to get her down to about 4. We were down to 8 millimeters initially post-op, and then as that thoracic kyphosis kind of settles, then she kind of gets back, 25, 20 at 2 months. So we can kind of track this over time and see, what do we get, and then what happens as we get further down the road. Do they, start getting more kyphosis? Do they get proximal junctional kyphosis, or do they kind of settle in a little bit and kind of stay there? And then here's her outcomes measures are improved after. So this case is a little more complex. So this is a 54-year-old guy, mid and low back pain. He has difficulty standing upright. He has a history of MS. It's not progressive, but he's got a little disability from it, kind of 4+ out of 5 in the right upper extremity. He has some spasticity. So he has a baclofen pump implanted. Very intelligent gait. And this is what he looks like. So this is, obviously a complex cervical thoracic lumbar deformity. He's got, flat back. He's got a big coronal curve. His coronal imbalance is quite a bit off to the right. And he's got some cervical deformity, so his difficulty with maintaining a horizontal gaze. So this is something in clinic that if I'm going to plan, what am I going to do with this? It's going to take me a while. I can tell him, obviously I've seen him a couple of times and we've tried conservative things and physical therapy, and he's worsening and his alignment's getting worse. We say, you know what, maybe it's time to talk about surgery. So this is our plan for him. I like to avoid 3-column osteotomies if I can. So we plan to, do multiple posterior column osteotomies in the lumbar spine, and hopefully get them relatively well corrected. So here's his post-operative films. So Sagittally, I think we got him pretty well aligned, and coronally not perfect, but much better than he was. The interesting thing I felt about this is, most of the time if somebody ends up with a CT to pelvis instrumentation, it's starts small and keeps getting added on and added on. I don't have too many that are kind of de novo C2 to pelvises. But the right side rod, that's one rod run. The left side rod, I cut and did some offset connectors, but I don't think I've ever had one rod run from C2 to pelvis. So I thought that was pretty interesting that patient specific implant can make one run from that whole way. And then here's kind of what he looked like before, what our plan was. You can see we got him pretty close, and that was our patient specific implant there. And then he's not too far out yet, but we can kind of look at our spinal pelvic parameters and see kind of where we were planning, where we got him. We're planning to get his PIL mismatch to 4. We got it to 11, so didn't quite make it. So this is one that I could go back and look and say, we're trying to get his SVA down to 13 millimeters. We got him to 4, and then by 1 month he was to 7. Maybe I should have been more aggressive with osteotomies in the lumbar spine with the 3-column osteotomy. But this will be interesting to watch and see kind of how he does, and look back and say, should I have been more aggressive? Obviously, if you get more aggressive with osteotomies, complication rates go up. If you have someone with a neuromuscular problem, it's always a balancing act. So I think that's where this doesn't necessarily help us a whole lot. That's where the surgeon decision making still comes in.
Hey, Andrew, can I ask a question?
Absolutely.
Yeah, we do all this planning off erect films or EOS imaging, which is excellent. Do you reckon we'd be more accurate though if we say used a lying CT scanogram to see what the patient's like, or even put them like prone in the CT just to see what they're going to be like on the table?
100%.
Because sometimes you see a film like that and you go, oh geez, that's like a double, triple osteotomy, but then they lie down and they're a lot more flexible, particularly if there's a neuromuscular type component. So
for sure.
Should we be using these AI tools based off the supine rather than erect imaging?
Yeah, that's an excellent point. And I think that, clinically, I try to do that. And right now, these tools don't necessarily factor in, supine imaging. So I typically get a CT scan before surgery for surgical planning, and then I can look at that scalp film and see, how much correction we get. And, this guy, if you probably guessing, he is somewhat flexible because it's a neuromuscular problem, and he lays down the CT scanner. He doesn't get perfect, but he corrects quite a bit. So that's why, we figured we could get by with, not too many posterior column osteotomies. In cervical spine, we got a lot of our correction just from putting him in traction on the Jackson table. So didn't need to cut any cervical osteotomies to get this correction. I think that's, definitely a future direction, using supine versus upright imaging and seeing what corrects, what doesn't, what's flexible, what's not. And then, also incorporating things like, CT scans. Right now it uploads the CT imaging and the MR imaging so you can see it all in one place. But it's not necessarily taking that into account when it's deciding, how much, correction we're going to get from osteotomies and stuff. And that's things that I think as surgeons we look at. If I'm going to cut a posterior column osteotomy, I look at that disc space, I look at the osteophytes, and see, how mobile do I think that disc space is going to be. But right now, a lot of it's like eyeballing it and, making an educated guess. I'm not always right, but I think that's definitely a future direction for this for sure. These are the coronal parameters. So it also looks at Cobb angles and stuff, so you can kind of see that. So one component of this software is data analytics, and so we can look at patient cohorts, and you can go and look at every PSO you did, or every 10 to pelvis or 4 to pelvis, and you can look at your Violin graphs, what they look like preoperatively, where you're planning to get them, where they are postoperatively, and you want your plan and your post-op to be similar. And then you can look at, I can look at, certain patients. So, my pointer here. So if I look at this patient, we're planning to get their PIL mismatch, around 16, we got it better. This patient, we're planning to get their PIL mismatch, down to 4. I think this is one of the ones I showed, and we didn't. We're 11. So I can look back at that and pull out that patient and say, why didn't I get the correction I was planning on getting? And then hopefully over time, this learns, the certain osteotomies I cut, the interbodies I do, which ones I get more correction, which ones I get less correction, things like that. Next case, so this is one where I wanted to include because this is where I thought the patient-specific implant was very helpful. So this is a 67-year-old female, similar story, progressive back pain, past medical history for obesity, lupus, obstructive sleep apnea, essentially intact, a little bit of an intelligent gait. Again, not terrible deformity. She's got a little scoli. Probably some foraminal stenosis at her fractional curve and the concavity of that lumbar curve. Sagittally, she's not bad. She's got a low-grade spondy, 4-5, maybe a little one at 3-4. But sagittally, she's relatively upright. This is what her MRI looks like. She's essentially got central canal stenosis at her spondy level, or 3-4, and then foraminal stenosis at multiple levels. So I didn't have a great stopping point here, especially with the low-grade coronal deformity. And she underwent the workup, conservative management, DEXA scan, and we offered to attend a pelvis with unit planning and patient-specific rod. So this is what our plan looked like. So we weren't doing anything crazy to try to, correct her sagittal imbalance. She looked pretty good, included interbodies at the bottom. And then you can see the reciprocal changes predicted kind of above that. And this is what she looked like on the table. And so if you look at those screw angles, she's pretty hyperlordotic laying on the table. And, if you don't realize this and you bend the rod just to lay in that lordosis, she's going to be way back. And I've made this mistake before, where I lay the patient on the table, do my decompression, I rod, and then, get some intraoperative films, but they're never great. And then they stand up and they're standing behind their pelvis. And that's a recipe for proximal junctional failure. So for her, I take my patient-specific rod and I say, she's way more lordotic than this rod, than what I planned on doing. So I used reduction towers to just pull her up to the rod and trusted that, that planned monolordosis was going to be, good for her. And, you can tell here, just looking back at that intraoperative film, she was way more lordotic laying on that Jackson table than she is when she stands up here. So I think this is one where that patient-specific implant really helped me to say, I have too much correction here, too much lordosis. We need to take some of that out and reduce this up to the rod to try and keep her, in good sagittal balance.
Andy, that's a fantastic example on the utility of the patient-specific rod. What table did you use in this specific case? And do you have the Pro-Access table?
We do. Yeah, I use the Open Jackson for a majority of my cases. I do use the Pro-Access specifically if I'm going to try and close a pedicle subtraction osteotomy, or if the patient's like kyphotic and I can put the table into kyphosis and then bring it back. So I do use the Pro-Access. I can't tell you that my corrections are any better or worse with that than the Open Jackson. A lot of my stuff I do on the Open Jackson table. So this is the Open Jackson. I think the other thing you could do would be, if you have a Pro-Access table, shoot those x-rays and look at it and say, we maybe need to put this bed into a little more kyphosis or something before we rod. But I really did like the patient-specific rods for this because I could really use that as a thing to say, this is where our goal is, this is where we need to get her. And vice versa, if you're doing osteotomies and you put that patient-specific rod in there and it's more lordotic than what you have, and you say, you know what, we maybe need to do a little more work to get a little more lordosis. So I find it, you know, I try to shoot intraoperative scoli films, but they're never great. And I'm trying to like eyeball measurements on them and stuff, and I just haven't found them super useful. I think coronally they're a little more useful to make sure that you don't fuse somebody, you know, correct their fractional curve and throw them off to the side. Sagittally, I haven't found them super useful, but I have found these patient-specific rods useful to make sure we get the appropriate amount of correction that we're planning.
And one quick question for this specific case: what measures did you take to avoid, and you know, apart from adequate and correct, and then adequate correction, not overcorrection, undercorrection, to avoid PJK? Did you use a tether at the top?
So it's a great question. I don't have the answer. I've gone through the gamut. I've used tethers. I've done sublaminar bands. I've done cement augmentation, and I can't say that any of my PJK rates were any better or worse with any of them. So I've kind of abandoned most of them. I know that a lot of people have a lot of opinions on them, and some swear by certain techniques. When I was using various techniques, I just couldn't say that it made a huge difference. I really think that I don't have the answer to PJK. I think that level selection and, you know, optimal alignment are going to be the answer. I don't think we know what optimal alignment is. I'm going to talk a little bit about some of the stuff we're doing to try to figure that out. It's early, but I think if we can figure out where that patient's spine wants to be with something a little more individualized than dropping a plumb line from C7 or from the EAC, I think that's going to probably be, you know, a better answer. But what do you use currently?
Spinous process augmentation. So a band at the UIV or UIV +1, and then you connect it to the rods, the specific system, and the invasive one we usually use at Northwestern, and it made a difference. I don't do a lot of deformity, but my partner does, and certainly the PJK rates have improved. But certainly the most important factor is the correct amount of correction, not overcorrection, undercorrection.
Yeah.
That's, and to certainly place the lordosis where it's supposed to be, you know, not.
Yeah. My anecdotal experience with tethers and bands was it seemed to delay PJK maybe. So instead of seeing it at their 6-week follow-up, it was a little further down the road. So maybe like kind of help hold things in place, and then over time, then it, you know, started to tip. So I don't know. Maybe that's okay. Maybe delaying it's okay, because the further out you get them, the more these muscles have a chance to heal, the more they're mobile, and so maybe that's all right. Yeah.
I agree. I misspoke. It's UIV +1 or +2, not UIV,
Yeah.
obviously, for the interspinous augmentation. Yeah.
Yep.
Mike, what do you use? What strategy do you use? You do a lot of deformity, and in order to
Yeah,
avoid
well, I
PJK.
mean, I think Ali said the other day that I throw everything at it, but I often I use sublaminar bands at the top, and say I go where, say you might go to T10, I always go to T9, T10 screws cemented, because sometimes that T9 body kind of like collapses over your T10 screws, or and so I cement the T10 screws to give that sort of buffer underneath. Then I cement augment the T9 vertebra, but it's got no screws in it. It's just got sublaminar bands. And I do those sublaminar bands via the tiniest laminotomy and don't disturb the midline at all. And it can take a long time, because with Nav and a good fellow, I got my fellow here with me today, but, you know, we fire in the screws so quick, and then I get to the top and it takes me half an hour to do some really nice sublaminar bands, mini laminotomy, but I think it's worth it. You know, my experience, similar to Andrew, I haven't eliminated PJK with that practice, but I suppose what I have really not seen much of is PJF. So, you know, the screws at the top, that really hard to soft area, you get the odd one. You get some PJK, of course, the odd one really bad PJF, neurological damage, etc. And I've never seen that with these sublaminar bands. So, but I like the technique of UIV +1 and 2, and occasionally I also do that if I'm really worried about PJK. I'll also add in an extra band going through there. So I think Chris Ames has quite a few papers on that, and it seems quite valid as well.
Mike, let me ask you. So I was using sublaminar bands for a while, and I got nervous. We had a couple patients here that developed almost like stenosis. It wasn't PJK, but they almost developed stenosis, like an inflammatory response, or like almost like a Charcot joint at the band level. Have you seen anything like that?
No, I haven't. I've been worried about it. I've MRI'd a few patients with funny symptoms afterwards, and I haven't seen it yet. I think it can certainly happen. Patients react. They react sometimes to metal. They'll react to the material in bands. It's a little bit random. The only problem I've had from bands, I hadn't had it. I've been using them about 3-4 years, and last week was my own personal first CSF leak from one. When we went in to do one, and the patient hadn't been able to have an MRI. They had an implanted cardiac device, but they had calcific dura on the CT through the whole thing. So I tried to do like a little navigator lavanotomy, and the burr had just gone, whoop, CSF straight away. So at that point, a bit of Takasteel, Tiseel, pack it off. It's not a problem, but no band then. So I go with the weave if that happens. That's my backup plan. Use that, but yeah, I agree it can happen. And putting devices in the canal that's why it takes so much time with it, because you're putting these sublaminar bands in, and also really inspecting the MRI beforehand to make sure they're not stenotic there already, because if they are, that's a contraindication. You don't want to try putting these bands through areas where there's already a fair bit of stenosis there. So yeah, they're not for every patient, and I'll look out for that, Andrew. I'm aware of that being a problem, but personally haven't seen it yet.
One question on here: are these preoperative measurement plans age adjusted? Yeah, they are, and you can specify your preference if you want to use age adjusted, sagittal balance goals or not. So this is that last case. So if you look at like the PLL mismatch, -7 to begin with, and kind of I think my worry was if I didn't have those, and if I just dropped, in situ bent that rod down into that lordosis, she would have been, -15 but got her back to about 0. Okay. So they don't all go great. So here's and I'd love some feedback if anyone would do anything different here. So 68-year-old female, again, similar story. I promise I see people that are different than this age group with back pain and difficulty standing. Obesity, hypertension, diabetes. She's had multiple prior surgeries, worked their way up. So now she's fused from T7 to L5. She's essentially intact. She stands kind of kyphotic. And this is what her x-rays look like. So she's got a very high pelvic tilt. She's, has a positive SVA, and here's her CT. So she's pretty fused, and she has interbodies. It's a little hard to tell, but 4-5, 3-4, 2-3, 1-2. And they're fused anterior. She does have an open 5-1 disc space. Anyone want to weigh in on what you do to get this corrected?
Yeah, I mean, that's a great case. So first of all, like first and foremost, medical optimization. She's intact, right?
Yeah.
Optimizing body mass index here at my institution, less than 35 BMI. So that's our cutoff. HbA1c should be optimized less than 7. You need to make sure she doesn't have osteoporosis. Get a DEXA scan, and let's say she gets clearance from the high-risk spine clinic. then how do you want to correct it? You got to take advantage of the bottom disc. Certainly, you know, an ALF hyperlordotic cage would be part of my plan, and probably you got to go up to T4 on this lady, and then see how much correction you get. But I would love to hear Dr. Selby's input if he's still there. Yeah.
Yeah, I think, you know, the 5-1 is a bit of an opportunity to help, right? And, you know, that's a big hyperlordotic ALF for me. Try to get a 25, 30 degree cage in there and take the facets off the back, although they look like they may be off already. So it might be a fairly mobile segment, and then carry on down to the pelvis. I would do this staged. It's too much surgery for me to do a really nice hyperlordotic ALF, take out the PLL, go to the back. And if she's solid through that segment, I'd probably, you know, cut within the fusion mass and fuse, say, you know, revision down from L3 to the pelvis with a bedrock. S2AI screws, and I use the SI joint fusion device there as well.
T3.
Then I'd reassess and do all this imaging again and look what needs to be done at the top level. Because if that, it does look solid through there. And so again, you know, you don't need to take down the whole fusion mass. You can add cross connectors and end-to-end connectors within the fusion mass at the top level too. So yeah, definitely a stage procedure for me, but I try to do the lumbar correction sort of all in one go, front, back, but not try to take on the thoracic before that. I'd reassess it afterwards.
Yep. So those are, you know, I think all great options, and I think this is, you know, where you know, you can, you know, she went through the whole workup and bone density and excuse me, make sure everything is optimized. I think the BMI optimization is a good point, and I think a lot of people have you know, certain cutoffs. We are currently writing up our data on BMI and adult spinal deformity correction, looking at low and high BMI. And we have some interesting findings. I think if we have too strict of a BMI cutoff in central Ohio, I'm going to be out of a job. So I try to optimize. I've had more luck with smoking cessation and A1C and every other modifiable parameter. So I kind of joke that, you know, but half serious, that, you know, BMI is probably a non-modifiable risk factor. You know, I can count on one finger that someone that's taken their BMI significantly down, going from saying got to get it down for surgery to getting there. I think gastric bypass is a powerful tool, but it's a process. Getting referred, the counseling, the dietitian, and it's a year before they get it. So I've certainly had patients that have had it in the past and then come and see me, but I have yet to have a patient where I saw, referred them, they went through the process, got it, lost weight, came back for surgery. Our findings are, I mean, they're interesting. So we show that patient-reported outcome measures, they get better regardless of BMI. Complication rates, both medical and we kind of split them into early and late. So early are medical complications, you know, renal, you know, acute kidney injury, any cardiac complication tends to be a little higher in high BMI, not surprisingly. And then late complications tend to be hardware, proximal junctional kyphosis, rod fractures, screw loosening tends to be higher. So I think at the bare minimum, counseling patients that, you know, revision surgeries is higher. But regardless of all that, you know, patient-reported outcome measures were similarly improved regardless of BMI. So we also were between, you know, vascular exposure surgeons for a little while, so I didn't have a great ALF option. So here's my plan for her. I plan an L4 pedicle subtraction osteotomy. You can see there. Plan to get 20 degrees there. 5-1 TLIF. Do this in one stage and take her to T3 with some pedicle, or excuse me, posterior column osteotomies above her prior fusion. So this is what our plan looked like in our patient-specific rod. And this is what she looked like post-operatively. This is immediate post-op, as you can tell by the staples on the x-ray there. So I think we got good correction of our PSO. You can see there, you can kind of see the prior peak cages in there and what they look like before and after. So you can kind of see how much correction we got. But like I said, they don't all go perfect. And so here's her most recent x-rays. So she's kyphosing above. She's got a bit of a fracture. You know, and so maybe this was something that, you know, I should have used a tether or sublaminar band or you know, a little more of a soft landing at the top. So I think, you know, I don't have it all figured out. I don't think the, you know, even though we got her where we planned, you know, obviously still kyphosed above. And so I definitely think there's some areas to still sort out. Next case is a little bit of a change of gears. So this is more of a degenerative case. So about 2 months ago, we started using this as not just a deformity correction software, but as a data collection platform. And this is kind of a pilot study. And so they currently don't have the capacity to do this, you know, every degen case for everybody. But I think hopefully at some point it's moving in that direction. So this is a 65-year-old physician, presents with back pain, bilateral lower extremity radiculopathy, no significant past medical or surgical history, has some diminished sensation, but is otherwise intact. And here's his x-rays. So he's got a low-grade spondy central canal, lateral recess, foraminal stenosis, some degenerative disc disease and disc-based collapse foraminal stenosis at L5S1. So after conservative management, we offered him an L4S1 TLIF using the Mazor robotic platform and unit planning. So for these, I'm not getting patient-specific implants. I don't think they make a difference with 1-2 level degenerative cases. But this is mainly to capture what their preoperative alignment looks like, what our plan is, what we get post-operatively, and then what happens to adjacent segments and their global alignment after. And so we collect these at each follow-up time point, and hopefully learn to kind of better predict reciprocal changes. And so like I said, this is kind of a pilot program. I think the interesting things to look at are, adjacent level reciprocal changes. Does that lead to adjacent level disease? What happens to global balance over time? And then comparing different approaches, A-lifts, T-lifts, laterals, posterior lateral fusion. One of our recent papers kind of looked at, different cage types. We looked at bullet and steerable banana cages for T-lifts. And the interesting thing was, if you put a bullet cage, you tended to not add as much lordosis at the index level. The adjacent level above, not the non-fused level, tended to get a reciprocal lordosis. So global lumbar lordosis was the same as if you used a steerable cage, banana cage. You got more lordosis at the index level and a reciprocal kyphosis above. So overall, globally, same. Where that lordosis was different. Whether they need to hyper lordose their adjacent level, or whether that adjacent level is allowed to actually kyphose a little bit. So once we get out to 5-year data, 5-year outcomes, we'd really like to look at does that influence adjacent level disease, if we can see a difference.
I bet it will, Andy. I think
that's our thought.
Yeah, I think with bullet cages, it's higher likelihood of adjacent segment disease. That hyperlordotic, you get lordosis sometimes where it's not supposed to be, but you can get buckling of the ligamentum flavum and all sorts of stuff. So I think ultimately banana cages are superior. The other thing is with bullet cages, you gotta take both facets out and do the same thing. Everything else is equal to compare. You know what I mean?
Yeah.
Because you tend to remove both facets and SAPs and everything, and
right.
With banana cages,
we controlled for unilateral fastectomy, bilateral fastectomy, what kind of osteotomy was done, to get the decompression and get the cage in and stuff. And really the only thing that came out significant in multivariate analysis was cage type. So what are we missing? A lot. Right now we're slowly, relying on alignment goals with this. We're trying to predict alignment. It's not going to tell me what alignment's optimal. So I think to the question before, is this age adjusted? But we still don't know exactly where that patient wants to stand. It doesn't factor in levels. I mean, you can submit for multiple plans. What does it look like if I do a 10 to pelvis versus a T4 to pelvis? So it can tell you differences in alignment, what you're able to achieve with different things, but it's not going to tell me, what patient needs to be brought up into proximal thoracic, what patient I'm okay stopping distal thoracic. It doesn't take into account things like bone density. DEXA scans aren't perfect. You can look at Hounsfield units at your UIV or UIV +1, but it's not going to help you take that into consideration for do I need to do more levels or not. It doesn't address other patient comorbidities, diabetes, obesity, center of mass, which I'll mention here in a second. It relies on surgeon preference and expert opinion. So, if I don't know what alignment numbers are going to be best for my patient, then, even if I get them to where I think they should be, it might not be right. And are we even looking at the right stuff? We were talking about this the other day. Patient reported outcome measures are fine, but they might not be telling us the whole story. So do we need to look into wearables? I know that's a hot topic now. Looking at patient ambulation, how far they're able to ambulate. And I certainly have patients that I saw last week in clinic. He had like an L1 to S1 fusion, kyphosis above, stenotic, myelopathic, losing his ability to walk. Osteotomies took him up. He's upright. I took a thoracic nerve root for my VCR. He's got a pseudohernia. X-rays look great. He's really mad, really not happy. And you can't say, well, listen, you weren't barely walking before, now you're standing upright, you're walking. They don't get it. They just know they're mad now. Why do I have this bulge here? So, I don't know what the right answer is. And then, as I mentioned with center of mass, alignment and sagittal balance, we're dropping plumb lines on standing films. But if I drop a C7 plumb line in a, person with a giant belly versus a, BMI of, 18, those are different forces, on those proximal levels. So it probably doesn't matter as much plumb line as it does, where those force vectors are, where that center of mass is. So I'll kind of finish with some of the stuff we're looking at. Other factors to consider, postural control and center of mass. So this is kind of our early data. We just got it accepted for publication, so it'll be coming soon. And this is not one of our patients. This is one of our healthy controls. It's one of our phenomenal medical students who did a lot of this data analysis. I actually presented this at CNS here recently. So, we all are familiar with, Dubocet's cone of economy. We wanted to look at, postural control and how, patients' ability to stand upright and how much coronal and sagittal sway they have, and if that's going to affect outcomes. So right now we have 16 patients in this trial. Just some of their spinal pelvic parameters, looking at PLL mismatch, we took them from 16 to about 5. Pelvic tilt we're less good at. SVA took them from 8 to about 2. T1 pelvic angle. And then we looked at basically postural control. And so to do this, we looked at coronal sway, so total coronal sway, coronal amplitude, so how far each way they go, sagittal total sway, and then sagittal how far they go. So they do 3 10-second sessions of standing on this force plate to capture the data. And then there's a equation that you use to look at head sway based on where their center of pressure and center of gravity is. So this is deformity patients versus healthy controls. So preoperative deformity, healthy controls, and significantly worse as far as their postural control. Pre versus post-operative. And so we made them significantly better after surgery. And this is 3-month follow-up data. So we kind of theorized that early on, this is probably going to get worse for a while. We're taking all those posterior muscles off the bone. They're going to have a lot of healing to do. But within 3 months, we saw significant improvement of their postural control. And then when comparing to healthy controls, so these healthy controls are like our medical students. So we're comparing like 70-year-old spinal deformity patients undergoing large long segment fusions with like mid-20s healthy medical students. And we didn't, totally normalize, but in some of them like coronal amplitude, coronal head sway, they were not statistically different than our healthy controls. So really saw some dramatic improvements in as early as 3 months. So this is early, but we definitely saw improvement in postural control, move towards normalization with our healthy controls. And when we get further, down the road, we want to look at, does postural control affect proximal junctional kyphosis, rod fractures? Does this correlate with their outcomes measures? Falls, if their postural control is bad, are they going to be, at risk for falls and stuff like that? And then we'd also like to look at using this preoperative data, where their center of mass is, to see if we can better predict, where their spine wants to be versus just using like C7 plumb lines and plumb lines from the EAC and things like that. So, all right, that's what I got.
Great, Andy. Can't thank you enough for this fantastic lecture. And I think we're past the hour, but I want to just spend a couple of minutes saying that AI, predictive analytics, is the future. I mean, it's so many advantages. There are more advantages, and I don't think there are any disadvantages. First and foremost, it would allow you to see in your hands what's the best option or solution. Because some people are better, or some surgeons are better at T lifts than A lifts. Some of them are better at D lifts than T lifts, and so forth. And looking at like the benefits and then the complication rates and risks in your hands, it's adaptive. Like, okay, you're having this pre-op image, and then these options, and then it adapts to the amount of correction you can get with each tool. So I think it's fantastic, and I think that's the future, in all honesty. And I'm interested to see what Dr. Baj has to say about this. And Ali, I tried my best to find the most recent virtual spine background. I know you sent it to me. I looked at my email, and then
actually I love that vintage look. It's great.
This is vintage.
Quite well. No, I'll email it to you again. How about that? I apologize. I came in a little bit late. We had a department meeting. Andrew, thanks so much for joining. And I caught the tail end of the talk, but yeah, I agree with Nader. I mean, this is such an important topic, and it's really the only way we can truly prove that we're working harder to make our surgeries better and safer. We don't have anywhere else. We collect data, we collect prospective data, we retrospectively look at our results, but I think really AI and predictive analytics is really the only way that we're going to be able to move forward in this field. So really appreciate you presenting, and hopefully look forward to having you back.
Absolutely. Yeah, I appreciate you having me very much. I think it's I agree with Nader and you. Like, this is the future, and there's definitely a long ways to go. But I think like you need to figure out the early stuff, alignment, predicting who's going to get better, who's not, for stenosis with low grade spondies. And it's just going to continue to grow. The more we learn, the more we're going to be able to expand this to different areas. I think it's great.
Yeah, I mean, what's the best outcome in your hands? It's like at the end of the day, like in the NFL, right? Like, the AI would tell you, okay, let's go for a 4th down, okay, versus a field goal. And it's different for different teams, because some of them are better at converting a 4th down. So sometimes you go with it, sometimes you don't, but it's more information. The more we know, the better. So thank you, Dr. Grossbeck, for this fantastic seminar. Who's next up on our list? I think we will figure this out this week, and we'll send in the flyer on Twitter for the next speaker. And do you know Ellie by any chance?
Yeah, I think it may be Dr. Mamagani, but we'll confirm, and like you said, we'll have the flyer out in no time, and the announcement for next week.
Beautiful. Okay,
one
yes.
couple of quick things in the chat here. Someone noted that some of the newer weight loss drugs are very promising and certainly more favorable than some of the surgical options. I think that's a great point. And then one question was, what's our revision rate for surgery for adult spinal deformity? In our paper that we're writing up currently, so our reoperation rate for all cause was for 2 years, which is, obviously can certainly have stuff further down the road, was about 9% for the non-obese group, and it was about 22% for the obese group. So as all comers, infections, rod fractures, proximal junctional failure, everything.
That's valuable information. Okay, thank you so much, everybody. Thanks, Andy. And then we'll see you guys next Thursday, same time.